Good evening, everyone. Thank you for joining us at Wu University. Tonight's webinar is Fighting Foggy Vision, the Role of the Tear Film in Scleral Lens Wear with Dr. Maria Walker. Thank you so much to my good friend and amazing speaker, Dr. Maria Walker, for joining us tonight. And thank you to all the wonderful attendees who are popping in. I'm Dr. Elise Kramer, your host, and I'm currently in Miami, Florida. Dr. Walker, where are you located?
I'm in Houston, Texas.
Oh, Houston, we have a problem. Next slide. Thank you to Visionary Medical Education for helping host this event. Next slide. And thank you to Tangible Science for exhibiting at this event. Thank you to Tea Pharma and Sun Pharma for supporting this event with the medical education grant. There is a pre-test that we all would like you to take if you can. There's going to be a link that's popping up right now in the chat. If you do this pre-test, we really, really appreciate it. These test questions help us keep these events free for you. So please do them. They allow us to get these medical grants for these wonderful events that we have here at Wu University. And just a few housekeeping items before we get started with our presentation. This is a 1-hour CE course. So for each hour of CE units, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. Also, the survey link will appear when the webinar ends, and CE certificates will be delivered by email and sent to our ARBA with OE tracker numbers. There's also going to be a QR code at the end of the event. So if you have the OE Tracker app on your phone, you can use that to scan it and get instant CE. If you don't have the OE Tracker app, you will not be able to use the camera on your smartphone, but it's okay because you'll still get the CE certificate emailed within 4 weeks. So don't worry if you don't have the OE Tracker app. You can ask questions using the Zoom on-screen floating panel that you see circled below. Next slide. And if you're using the mobile version, you'll find the Q&A on top. And to get to the chat, you'll have to click on those 3 dots at the bottom to find more options where the chat is. Try to keep logistic questions in the chat box and questions for Dr. Walker in the Q&A. I will be screening through the questions and hopefully we'll have time to answer many of them at the end of the presentation. Next slide. So our speaker tonight, who really needs no introduction, is Dr. Maria Walker, MS, PhD. She's a clinical scientist with a focus on keratoconus, childhood myopia, and specialty contact lenses. She graduated with ODMS from the New England College of Optometry in Boston, Massachusetts in 2013, and then completed a 1-year cornea and contact lens residency at Pacific University in Portland. She joined the faculty at University of Houston College of Optometry in 2014 and went on to complete a PhD on the impact of a scleral lens on the eye in 2021. Dr. Walker is currently an assistant professor at the University of Houston and runs a research lab studying keratoconus, the tear film, and the effects of scleral lenses. She is also an investigator on the BLINK study to evaluate the use of soft multifocal contact lenses in reducing myopic progression in children and provides specialty contact lens patient care 2 days per week. Dr. Walker is a fellow in the American Academy of Optometry, a past president of the Scleral Lens Education Society, an advisory board member of the Gas Permeable Lens Institute. Thank you so much once again, Dr. Walker. I always learn so much from you, and I'm super excited to learn even more tonight. And I will be on later for questions.
Thank you very much, Dr. Kramer, and everybody for having me. Thank you, everybody, for joining. So yes, as advertised, I'm going to talk tonight about foggy vision. So specifically the role of the tear film, but really we're going to break it down and talk about all types of foggy vision and how we figure out what each different type kind of means for our patients. So I'm assuming that most people on this know what a scleral lens is. So of course it's a rigid lens that vaults over the cornea, and then just drawing your attention to the bottom right of the image, right? We just to sort of lay it out, we've got several different layers where, quote, fog could occur. Of course, it can happen on the surface, so the very front surface tiers of the lens. The lens itself, I guess, could be foggy, but that doesn't really happen. Certainly the fluid reservoir between the lens and the cornea, and even in the cornea itself can get foggy. And, you know, it can even fog up behind those, but there's really those sort of three main areas, the surface of the lens, the fluid reservoir, and the cornea itself that can fog up. So who wears scleral lenses? Well, the most patients, certainly here in the United States, wearing scleral lenses are going to have keratoconus or some other type of irregular astigmatism, maybe post-RK, maybe post-transplant, post-refractive surgery. This is the most common indication, this irregular astigmatism indication. We also see a lot of patients, and it really increases year after year. I know in our practice, certainly, we see patients with ocular surface diseases being managed with scleral lenses, either due to exposure or due to vision that because of that exposure is reduced without a lens. Now, this is the population, this ocular surface disease population, that's probably at the highest risk for these tear fluid anomalies, right? They have poorer tear films in general. They tend to get a little bit more of the midday fogging, which we'll talk about sort of in the middle of this lecture. But certainly ocular surface disease, when I have a patient I'm fitting in scleral lenses and they have ocular surface disease, I'm always watching out for foggy vision on one of those layers because they seem to be predisposed for really all the different types of fogging that they can experience. So, okay, so the scleral lens experience, we know most people, it's much improved vision, much improved comfort. But just like with any type of contact lens, we're always balancing the pros and the cons of a treatment. And so that good comfort, good vision, really the lack of serious complications is counterbalanced a bit by obviously handling issues that some people are limited by. But there's also these kind of annoying and unique complications that can occur. And so, you know, of course, the title of this talk and this talk that I often give to in different forms to different people is because people often complain of this very common complaint of my vision is foggy. And so the first thing is figuring out, as I said in the very beginning, is which layer is the fog coming from? So of course, refractive blur can cause fogginess, but most of us are pretty, you know, simple over refraction will tease that out. And then you have to start to look at the three different layers. So you can have fogging on that lens surface if the lens isn't wetting properly, if there's excess debris that's accumulating. You can have fogging in that fluid reservoir, so midday fogging. This is what most of my research, or some of my research is on, but we certainly are learning a lot about what that is and how we can mitigate it. And then, of course, you can have swelling and some other things on the cornea that can cause sort of a fogginess to the vision. And so really the two steps that we take are, one, asking the right questions. You can usually determine what the cause of the fog is just by asking questions. And then we can look to confirm. And so the questions that we ask are typically, well, how long does it take for this to occur? Does the fogginess sort of last forever? Or if you blink, does it get better for a moment and then it gets worse again? Or do you take the lens out, refill it with solution, put it back in, it goes away? So each one of these will have unique answers that can sort of lead you to the right solution of what's actually happening to it. Where the actual fog is coming from. So then we look at the different layers, of course, the lens surface, the fluid reservoir, and the cornea. So let's look at lens surface fog first. So this is something that's very easy for us to detect. We just look in with a slit lamp, kind of diffuse light, low magnification, and you'll see these areas of sort of non-wetting. They'll often be patchy. Sometimes it will be the whole lens. Sometimes it more looks like deposits as opposed to non-wetting. This is the one where it might happen immediately. Typically, this is going to be immediately when the patient puts the lens on. The lens can dry out and not wet after several hours of wear, but that's really the exception, not the rule. Usually, if it's a lens surface issue, it's going to be foggy right when they put the lens on. They can often take off the lens and look at it and see kind of a smeary fog on there. So asking the patient kind of really specific questions of like, tell me what you mean by foggy. Do you take the lens out? Does it look foggy? Clean it, put it back in, it gets better. Okay, that's something that's probably a lens surface issue. It might look a little bit like looking through a dirty windshield. That's typically the analogy that I provide to patients. Although, if I'm being honest, most of these types of fogs look like looking through a dirty windshield. So I wouldn't use that on its own, but it can be helpful in sort of empathizing a bit with the patient on what they're going through. Poor lens deposits, right? This is an example where you have deposits on the lens, right? So it's a little bit different from non-wetting, but very related, and often the two will go together. This can be related to the lens or not related to the lens. It's not usually the lens fault in my experience. This is, every patient has a different tear chemistry and eyelid health. So sometimes it's an eyelid tear film hygiene thing. Sometimes the eye just responds to a contact lens, makes a lot of proteins. Those proteins can be sticky and stick to the lens. So there's a lot of different causes of this, but again, non-wetting deposits kind of go hand in hand in how we manage it. Lens materials, not really. All of our lens materials are pretty good. It's not typically a material specific thing. But it can be a solution related phenomenon if patients are either not using the solutions we recommend or using them incorrectly. So I always, when I see non-wetting or surface debris, the first thing I do is have a really overly in-depth conversation with the patient, exhaustive conversation sometimes, about the cleaning process. I wear scleral lenses now, so it actually has helped me a lot in training. So I'll often take my lens out, give it a good clean. I'll show them how to rub the lens. Sometimes we'll give them little tools. These are this photo in the middle here are these little contact lens sponges that you can order on Amazon. They can help if you've got a particularly deep scleral lens. Sometimes people get deposits on those deep scleral lenses. They can't clean the inside of them quite as well. We know there's alcohol-based cleaners. Don't want to use those if the lens has any type of coating on it. There's also multi-purpose cleaners, peroxide, enzymatic cleaners. These can all be used. And honestly, what works for one patient doesn't always work for another patient. I had a patient actually this morning who I actually put a drop on 3 of his different fingers of these three different multi-purpose cleaners to show him they have different viscosities, they have different thicknesses, and you may prefer one over the other. So sometimes you just have to do a little bit of trial and error, see what works with different patients. But I will say the one thing is rubbing the lenses, and I find that using a surfactant cleaner, so something that gets sudsy. So I tell the patient, if you're cleaning the lens and it's not getting sudsy, grab some dish soap. That's what we use sort of over the counter. Or put a little bit of saline, mix it with your multi-purpose, see if you can get it really sudsy, and really try to break down those lipids and get that lens wetting. So sometimes you have to work with the patients on this, but it's usually a relatively manageable problem to have. Now, you have to discuss in the context of lens non-wetting and lens deposits, eyelid and eye surface hygiene are really, really important. So patients who have blepharitis, MGD, dry eye, that's all obviously going to affect the lens. And so especially, like I mentioned, these ocular surface disease patients, which are going to be at the highest risk for every type of sort of fogging that happens, and make sure we're using all the different tools in our toolbox. And I've actually gotten a lot, as I've seen more ocular surface disease patients come into our practice, I've more and more done like coordinating care with the dry eye clinic that we have, because they've actually been using low light level therapy, RF radiofrequency therapies, and the different meibomian gland expression systems, along with things like artificial tears and other like even pharmaceuticals, to manage the dry eye. And so it's, oftentimes these patients, especially if they have something like MGD here, a picture like this, right? That's not going to be solved by a scleral lens, right? Scleral lenses are providing a shell of protection for exposure-related dry eye and exposure-related pathologies and ocular surface disease. They are not going to improve the tear film. They will, if anything, make the tear film less stable, and they are certainly not going to improve meibomian gland dysfunction. And so you want to make sure that you're treating these as much as possible before they even go into the lens, but also wearing the lenses. And just a quick example of one of my favorite patients. This is her right eye on the left and left eye on the right. The non-wetting lens here is her left eye. And essentially, this is a patient, we tried every different solution. That was an easy thing to try. We tried coatings, we tried different materials, and then we finally basically went to managing it with dry eye therapies as well. And what made us sort of trigger and say, we really need to see if we can maybe treat this tear film is because we were looking and we have this nice higher resolution microscope, and you can see the right eye tear film here. You almost can't see anything because it's very clear. There's not a lot of reflectivity, versus the left eye's tear film you could see had a lot of debris and refractiveness. So this was a patient who actually her lenses are wetting pretty well. She still struggles with it, right? So you can help and give patients all these tools. Sometimes they still have good days and bad days. That's for sure. And of course, we have surface treatments as well. So if patients come in that ocular surface disease category, certainly if they have a lack of tear production, so I know that they're not going to be producing the normal tears, I'm going to do a surface treatment with HydroPeg, which is essentially a polyethylene glycol or PEG-based coating, and that's a very lubricious, sort of water-loving molecule. And so this really works well for patients who need that extra kind of coating to create a more lubricious lens, and it can help the lens wet, certainly when they're starting out. And we do have an option to boost the coating every 30 days. And so if you do the HydroPeg coating, you can definitely recommend that the patient sort of do this sort of boost, which is very similar to like a Progent, where you have two solutions and then you let the lens sit in them for 30 minutes, and that sort of boosts up the coating. So to summarize this sort of lens surface fog, so can occur immediately, can occur several hours after wear. Usually it's going to happen pretty soon after the lens is applied. And it may improve. This is one where if you ask patients, if you blink and then open, does it improve it? And it may improve, it may not. Often can be managed with thorough cleaning, education on cleaning, as well as maybe using a surfactant or a soapy cleanser. And then, of course, long-term management, if this is a chronic issue, may require you to think of all the different approaches, right? So the different things that you can do with the lens coatings and the solutions and the instructions on the solutions, as well as managing things like blepharitis, dry eye, tear film, things like that. So now moving into my favorite type of fogging, the fluid reservoir fogging. Midday fogging is what we'll focus on, but that's not the only reason that the vision can be foggy because of something going on in the fluid reservoir. So you can also have, of course, an application bubble. This is pretty easy to detect. Most patients can detect this. They either feel it or they can't see because it's foggy. You remove and you reapply the lens, and that problem goes away. The other thing, which we tested out recently because we had some patients asking about it, and we were, these milky artificial tears. So sometimes we'll talk in a little bit here about using different preservative-free artificial tears as an application solution. I'll say now, these ones that are milky, that get clear when they're on the eye, that does not happen when you do it with scleral lenses. So don't use these milky solutions. I had some patients that we had recommended this, and then they let us know, and then we tested it out. And of course, these are going to stay milky. So just patient education. We've also had patients use and many of you probably have as well, had patients use their multi-purpose solutions, which of course have preservatives in them. So you don't want to use those to fill the lens. I'll show an image of that at the very end, actually. But midday fogging is the most common type of fogging that we see in the fluid reservoir. And this is can be a sudden, more likely this one will happen more gradually. And it'll look like a pretty dense clouding or fogging. Does not change with you when you blink, and it usually will be either constant or gets worse over time. It doesn't typically improve after it's sort of become noticeable to the patient. And it does improve when the lens is removed and reapplied with fresh solution. But a lot of times patients say it starts to come back immediately or completely comes back pretty quickly. And of course, this is when you get debris that accumulates in this fluid reservoir here between the lens and the cornea. So what is it and how do we mitigate it? Well, first we'll just kind of briefly go through what it actually is. So there's several aspects that we've studied in our lab and that other people have looked at as well. But proteins, lipids, cells, as well as the inflammatory impact have been evaluated. We're really just going to focus today on the lipids and the cells because I think that's where the story is. And as much as I love to talk about the other things, it's not as much so clinically relevant. And so I have found that it's maybe not as interesting to everybody as it is to me. So we'll leave those for another day. But the lipids and cells. So in terms of lipids, it's really the non-polar, right? Non-polar is the non-miscible. That's how I remember it, right? Non-miscible in water are the non-polar. So these are the lipophilic or hydrophobic lipids. And we have found three sort of species that are increased in midday fogging, one of them being triacylglycerols, commonly called the tags. Note that if you look at the chemical structure of these, they have these long chain fatty acids. Those tend to be very hydrophobic. Probably these are from cells, specifically from the lipid bilayer in the cell membranes. We also see an increase in wax esters and cholesterol esters, which are also, if you look at their chemical structures, have these long chain fatty acids, which essentially create a lot of hydrophobic properties. And these are almost certainly coming from the meibomian glands because these are the two primary lipids that the meibomian glands secrete. So we see an increase in these non-polar lipids that are accumulating in that fluid reservoir. And then there's cells, of course, that we find, maybe not of course, but there's cells that we find increased in midday fogging. And this has been shown in our lab, and it was actually first shown by my friend Cameron Posnikoff, who did his PhD looking at dry eye, and he actually had looked and was the first to show that there was some cells in the fluid reservoir, and we've been able to show the same thing. What we're looking at here is basically just a sample taken from that fluid reservoir from a patient with midday fogging, and we stain it with something called an H&E stain, which allows us to visualize the cells. So what are we looking at? We're looking at these larger cells, are epithelial cells, probably corneal epithelial cells, but there could be conjunctival epithelial cells in there as well. And then granulocytes, which essentially are mostly neutrophils. If you zoom in on these a little bit here, you can kind of appreciate that tri-lobed nucleus you may remember learning about in biology. And that's the cells that we see accumulate in there. Just a brief reminder, neutrophils are part of the innate immune system, and so they're sort of that first line of attack and they're indiscriminate. So it sort of makes sense. You put this piece of plastic on the eye, it's going to compress some of the blood vessels in the conjunctiva, and so neutrophils are released as sort of the attack dogs to make sure that the insult is not something that needs to be phagocytosed or something. So that sort of begs the question of whether or not there's different sort of types of midday fogging. And I think there are in a way. And I will say as a disclaimer, nobody's actually looked and tested different kind of looking midday fogging and what's in there versus midday fogging that looks one way or the other. So that being said, I have some thoughts. I have some hypotheses about it. And so when we see this diffuse, and this picture is a little bit more exposed than the one next to it, but when we see this more diffuse, very milky looking midday fogging, this may be more based on lipids. And when we see these more focal punctate sort of pieces that look kind of like cells or clumps of cells, maybe it's more cellular. And that makes sense, right? Lipids on their own are going to be much smaller than a cell. They're part of cells. So, some of it is size, but also, the lipids sort of precipitating out into the aqueous makes sense. It might look a little bit more sort of milky. In most people, it's probably a mix of both. And at the very end of this sort of section, I will show you an example where we definitely have a mixed type in one patient. And I'll also mention, most of us, if you're a clinician, you know this, MDF or midday fogging is going to occur with a range of severities. So I no longer really say, oh, they have it or they don't. I sort of grade the rank or the degree of midday fogging, which they do have if they're complaining of it. So looking back at, our two kind of categories and clinically what we can maybe do to mitigate midday fogging in these patients. Well, the obvious thing and the thing that we do a lot of times clinically is use something that is a lipophilic application solution, right? Something that is not going to cause precipitation of lipids into an aqueous solution. So preservative-free artificial tears are a nice kind of obvious choice to use. As far as it makes sense with the lipids, as far as the cells, maybe using the lipophilic, but really that more speaks to reducing pressure on the landing zone potentially, right? And again, this isn't tested, but this just makes sense logically that if you do subscribe to, the cells being there because of some sort of mechanical stimulus that's creating this response. And again, anecdotally, people have found better alignment can reduce on that landing zone, on the conjunctiva, can reduce midday fogging. So first things first, though, you can modify the fit. I think most of us have, 10 years ago, midday fogging was like most of the patients. Now, it's probably only significant in 15 to 20%. We still say 30, 40% in the studies, but I really think in the past 5 years, we've learned so much about how to modify the fit that most patients, we can at least reduce some of the midday fogging by reducing the overall clearance, especially reducing the clearance over the limbus. I think this is really where that, big, wide limbal angles just really sucks up that debris material into lipid cells, whatever it is, into the fluid reservoir. And you can see this example of just taking 310 microns of clearance and reducing it to 150 microns of clearance, reduced the fog pretty significantly for this particular patient, shown as an example here. You can also change the landing zone of the lens, again, to align to the conjunctiva more. And, there's variable success with either of these changes, but usually it can be pretty substantially reduced with a new fit. And then, like I just alluded to, application solutions are certainly used. And sterile saline is the most used, and that's where the FDA approvals are in application solutions for scleral lenses. We have non-buffered solutions, so pH of 5, just regular 0.09 sodium chloride, 0.9% sodium chloride, which is saline. And then we have some solutions that are buffered either with boric acid or with sodium borate. And then we also have a solution that's phosphate buffered and also has some added ions. So those are kind of the standard saline solutions. In terms of, using an off-label solution to reduce midday fogging, there is some evidence, which I'll share here in a moment, that that solutions that preservative-free artificial tears can reduce midday fogging for some individuals. You do have to just make sure we're considering solution must absolutely be preservative-free, and we don't want to use multi-dose. So this is one of those things that I kind of get a little bit on my soapbox about in terms of using the multi-dose preservative vials. I think we're seeing more and more of these multi-dose preservative-free vials of artificial tears. I really do not like the idea of using those with midday fog with any patient with scleral lenses. You're essentially taking this, you know, solution and using it, and it can potentially get contaminated using it over and over. So I'm really kind of strict with my patients. Not a huge fan of them using those anyways. But they definitely have to be the single vial preservative free ones in these cases. So we did do, we are in the middle of a study actually looking at the use of these preservative-free saline solutions in the fluid reservoir to reduce midday fogging. What we've found so far, which is pretty promising in this case, is that saline created a score of about twice as much of midday fogging compared to preservative-free artificial tears. And so we were pretty pleased with that. And we're still continuing the study to see what happens with that, but it can help. Now, I want to go back to this, are there different types of midday fogging? Because one of the things that we found in this study, I found was super interesting because it really, I think, showed some evidence that there are different types of midday fogging, but that it's probably mixed in most people. So if we look at this example, so this is a patient who clearly has pretty dense midday fogging. This is an OCT image, of course. What you can see is that there's quite a bit of diffuse fogging, but there's also these punctate areas of fogging where it kind of looks like there might be a mixed fogging. So maybe some lipids as well as cells. Now, this was an interesting case because when we used preservative-free artificial tears as the application solution for this patient, you can see what actually happened in that fluid reservoir. And this is actually one of the cases that really started me thinking a lot more about the distinction between sort of different types of midday fogging. So you can see as soon as she used preservative-free artificial tears, which are, again, a lipophilic solution, you see a massive reduction in that sort of diffuse-looking fog underneath the lens. But you still have those punctate areas where there's clearly some cells that are still present. And again, I think that most of these are epithelial cells. The reason I do is because a lot of times you can actually see them coming off of the epithelium, but certainly there could be conjunctival epithelial cells in there as well. So again, on this point of are there different types? Yes, there probably are. And in most patients, it's probably somewhat mixed. So to summarize the fluid reservoir fogging, so again, we think most of what's happening in midday fogging in the fluid reservoir is primarily caused by lipids. I will actually, I think I put a slide in here. I think I am going to skip to it really quickly in just a second. So you can see this is actually a study that we did. I put it in my extra slides, but I think I'll have time, so I'll go through it. And I won't go through it exhaustively, but it's really on the question of whether or not midday fogging causes inflammation. Because we talk about, okay, what's it caused by? It's caused by these cells, but they're immune cells. So is this actually causing inflammation? And the answer is that maybe it is actually slightly causing some inflammation. And what we're looking at here in this figure, I can kind of walk you through it. Simply, if you look at this this A column here, this untreated, untreated column, that's basically a cell that is responding positively. It doesn't have an inflammatory response. And what we're looking at is a bunch of little epithelial cells that were cultured in fluid reservoir from midday fogging and not from midday fogging. If you look under this TNF alpha column, and just ignore these blue images, if you look under this TNF alpha, when you see the green spot sort of concentrated towards the center of that cell, that's indicative of an inflammatory response. So knowing these two, if we look at our fluid reservoir, if we look at this top one, this is a patient who had a dense midday fogging collected from their eye. And this bottom one here, B, is where the patient had no midday fogging. And you can see that the fluid reservoir image more closely matches our sort of inflammatory response than the untreated, which was the non-inflammatory response. So in that tone, as that little aside, going back to sort of the summary of fluid reservoir fogging, to answer that question of, does this cause inflammation? The response is probably it is causing some epithelial inflammation. And so it is important to manage, and it is important even if it's not affecting a patient's vision. So again, mostly caused by lipids and by cells. Now, in terms of what we can do and what we talked about doing to mitigate it, of course, we have those fit modifications. So reducing apical and specifically reducing limbal clearance are going to be your most effective changes to make, and as well as aligning the landing zone so that you have even landing on the conjunctiva. Product modification, so we can use preservative-free artificial tears as the application solution. Now, one thing I didn't mention, but we certainly have a lot of patients that do this, is whether or not they have to use like an entire vial per lens when they put it in. And the answer is no. It can be used alone, or it can be mixed with either our ion rich, which is what I prefer to do if the patients have access to it, so that iron enriched, so the neutrophil saline, or the regular saline, so any of the salines that you're using, as long as it's preservative free. So patients can sort of figure out what works for them. And I say try different ones. I have a few brands that I like, but really I have patients try the different ones, and they go generic a lot of the times too, until they figure out what solutions work best for them. In terms of modifying their cleaning solutions, I have not found, and there's really no evidence that cleaning solutions are going to affect it one way or the other. You may anecdotally have found one thing or another, but I haven't, and I don't think anybody, I know nobody's done an actual study looking at it. So I know the scope people didn't find really any association, I don't think. So in terms of patient modifications, again, we talked about treating things like allergies, blepharitis, dryness. We have new medications for Demodex blepharitis as well. So there's all sorts of different ways to treat underlying conditions that can exacerbate midday fogging. Some people find that doing an eye wash is helpful. I had a patient this morning actually who was asking about this, and I told him, a gentle eye wash, particularly, if you're putting the lenses on pretty quickly after you wake up in the morning, giving yourselves a couple, I say like gentle drops of saline before you put the lenses in, or even some artificial tears just to help sort of clear out that eye before you put the lens in, that can be helpful. So one sort of comment, overnight when we sleep, you get a ton of immune cells that come out onto the ocular surface. So when you wake up, it takes 5, maybe 10 minutes for those cells to sort of wash out and get off the ocular surface. So sometimes just explaining this to patients and saying maybe just take a drop or two of a tear to help rinse this out before you put the lenses on can go a long way. What I don't want patients doing is like power washing the surface of their eye when they wake up, because that can cause more issues than it's even helping, because then you can create an inflammatory response simply by, rinsing and washing the eye to roughly. So that's sort of the summary of fluid reservoir fogging. So in the last 10 minutes or so, as we finish up, I'll just go through the final area of fogging that can occur, which is on the cornea. And we'll focus on corneal edema. There's other ways that the cornea can be foggy too, but corneal edema is the most sort of common and scleral lens specific phenomenon that can happen. Thankfully, it's pretty rare. We don't really have any incidence data on how often corneal edema occurs. I would probably put it at somewhere about maybe 5%, which is not nothing. But it's going to be relatively uncommon in most of our patients. This one's going to take several hours to occur. Typically, think I've got a couple of patients, I think one who would sometimes get edema after just an hour or two, but usually this is like at hour 6 or even way later, like hour 12 or 15, because it's after the lens has been on for a long time. This one, the key is that it's going to be accompanied by discomfort, redness, irritation. Patients are going to take the lens off and it's still going to be blurry. They put the lens back on, still blurry. So this is typically going to be relatively straightforward to diagnose if you know how to ask the right questions. So again, several hours of wear doesn't improve with removal and reapplication, although keep in mind, if it's happening at the very end of the day, patients will oftentimes just take the lens off and leave it off, in which case you can probe a little bit about saying, oh, is it blurrier than it seems when you take the lenses off otherwise? But be careful on patient recall bias on that one, because sometimes they, keratoconus, they may think it's more blurry, but they're not really good reporters on that. So it's more the irritation and pain and redness associated with it. And again, if you can tell them, sometimes I'll tell them, okay, well, when it happens, take it off, put it back on. I know it's 10 o'clock at night, but just do it to see if it gets better. If it's still blurry, let us know. That might mean something else. And again, oftentimes the eye is going to be pretty red. So confirming corneal edema. So I always like to, I have found that a lot of patients, particularly transplant patients, think that they have corneal edema, but it's not actually corneal edema. It's something else. It's maybe midday fogging. It's maybe that their lens is drying out a little bit, or maybe it's we don't know. We can't figure out what it is, but it's not corneal edema. And specifically, so I'm pretty stringent about confirming objectively that there's corneal edema and not just assuming because of patient symptoms and what they're saying that it's corneal edema. So we'll typically do provocative testing to do this. So of course you need to have baseline data to start. So ideally we measure this before they even start wearing scleral lenses, but in a few occasions, especially if I was really concerned that edema was happening, and I don't have a baseline, I may have them stay out of the lens for a day or two, come in for a scan, and then wear the lens and come in for, so I may make them kind of wash out to get a new baseline. Again, if you're worried that they have true corneal edema, you need to do something about it. So you may have to do that. Or you just make all the changes and hope that it goes away. But and then you have them wear it for as many hours as possible, at least 4, but ideally like 10 hours, however many hours it takes for them to report edema, that's how many hours you want them to wear the lens before they come in. And then when they remove the lens, I'm pretty, again, specific about this because you want to make sure your data is showing you what's really going on when the lens is on the eye. So I remove the lens like one eye at a time. And as soon as the lens is removed, we literally do it at the instrument. Their chin goes in and we measure their corneal pachymetry. And so then you can look at the difference map. I always do global pachymetry because a lot of times you're going to get swelling that's outside of the central cornea. And so in this case, The patient had 26 microns of swelling centrally, but almost 100 swelling inferiorly. And this was affecting their vision, because you can see it's kind of creeping in here. And it was more than affecting their vision. They were getting sectoral hyperemia and some discomfort. Note here that you do expect to have some amount of swelling. So you're going to get 20 to 40 microns of swelling with normal scleral lens wear. Typically, when it gets over about 50 microns, that's when you start to see problems with discomfort, problems with blur, and just generally something that you do something about it. So in terms of what we actually do when we have corneal edema, well, the first step is incredibly easy. It's increase the DK of the lens as high as you possibly can. We have lens DKs of 180 and 200. Those should be sufficient. So you increase the DK as high as possible. I also would say make the lens as thin as possible. So if you've got a high plus lens and it looks really thick, which you'll be able to tell, you can look on the invoice or you can look on your OCT and measure it. If it's a thick lens, try manipulating the base curve and the power so that you can reduce the amount of plus power in that lens to make a thinner lens. There's been a lot of cases where I've seen some corneal edema or suspected it, and then we look and the lens is really, really thick. And so as soon as we fixed that, the problem went away. Then we bring the fluid reservoir down to as minimal as possible for that patient. And then if everything we do then is still not working, then I'll typically start to play around with my edges a little bit. And so we can basically see if we can maybe increase the amount of clearance or amount of tear exchange that we're getting to increase the amount of oxygen available. So corneal edema, fortunately, not so common, but when it does occur, it is pretty serious and can be dangerous for the cornea. And so we want to make sure that we're mitigating it. And the more diseased eyes you see, the more you're going to see corneal edema, because it typically happens in transplant patients. Neurotrophic patients are hugely at risk. If I were to hypothesize, those would be my two highest risk populations for sure. And then, it can happen in anyone, but those ones you really got to watch out for it for. Okay. The sort of last but not least, the corneal fog that is not caused from actual corneal edema. So edema is not the only reason that you can have corneal induced fog. Now, of course, if you have a scar or something, some haziness of the cornea, you're going to get some fog. But on that surface epithelium, there's two decently common things that will happen. The first one, and I said I would show at the end a picture of using unique pH. So that's one of our multi-purpose solutions. Using unique pH as an application solution will probably cause the cornea to look like this. And that's just classic preservative toxicity, preservative staining. So you want to change the application solution if you see that. And that's usually just an education. I've seen less severe versions of this with patients who swear that they use saline, but don't rinse the multi-purpose solution out of the bowl of the lens. So you want to make sure you're educating patients on not only filling with their solution, but especially if they're storing it in a very viscous multi-purpose solution overnight, they want to make sure that they're rinsing out that inside bowl so they don't have a coating of that preserved saline leaching off into their fluid reservoir throughout the day. You can also have, this is a patient who actually came in this morning for a follow-up. This is a post-transplant patient who has a heck of a time. And this is actually one of the patients who swore that he was getting edema, but we really did a ton of provocative testing and could find no evidence that he was getting any corneal edema. But what we did notice is that his corneal epithelium is really, really rough. And this is a patient who is still taking several preserved glaucoma medications and steroids. We're trying to get him access to non-preserved medications, but it can be more challenging with some patients, especially if they don't have good insurance and good access. So at this point, he's still on the preserved medications because cost at this time is prohibitive, and we're having trouble getting access to non-preserved. And you can see this is an image with his scleral lens on. You can just see how much his epithelium lights up here. And so, we measure it. It's somewhat edematous, I suppose you could say, but it really is not holding any fluid. It's really, really rough. So this is, one of those things you kind of have to watch out for, especially with patients on a lot of medications, really diseased eyes, like a transplant in this particular case. Okay, so just summarizing up, and then I think we have some time for some questions. So, again, we've got three main different ways that you can see foggy vision with scleral lenses. Lens surface, which can be due to all sorts of things, everything from patient hygiene to deposits or to just non-wetting of lenses due to poor cleaning. So we can we can change solutions, add coatings, and really don't forget the other tools in your toolbox in terms of managing dry eye and eyelid disease, things like that. And then midday fogging, reducing the clearance, changing the application solution, easing up on the landing zone can be really helpful in mitigating that. And then, of course, with corneal edema, or these other epitheliopathies, sometimes reducing clearance, increase the lens decay, to manage that.